Okay, thank you. So may the recording begin, please. Yeah, thank you for coming. This is a welcome to this Health and Wellbeing Board meeting in Council Chamber, County Hall on Thursday, 12th January, 10 a.m. So our first item, apologies for absence. Is there any apologies?
Yes, there's apologies from Mark Hall, Suzanne Lamb, Liz Morgan, Guy Renner-Thompson and David Thompson.
Thank you. Thank you, Leslie. All right. Now to the second item, the minutes of the previous meeting held on Thursday, 8th December. Can I pass them as a true record? Yes, please. Thank you. Yeah, thank you. Third item, disclosure of interests. Any conflicting interests or potentially conflicting interests, you may say. I see none. Thank you very much. Okay, so that brings us to the main item, the fourth item, one of the main items here, that is annual report on child death overview panel. Okay. And this is going to be a brief report, I was told by Alison Johnson. I welcome her for coming here to present that one. I would encourage, after the presentation, a good comprehensive discussion so that we can get a comprehensive view of this sensitive subject, very important subjects about death of children. Okay, and then we will try to see how we can go forward. Thank you, Alison. Can I welcome you?
Thank you. Yeah,
please,
thank you for
the floor is yours.
Good morning, everyone. So I'm Alison Johnson. I'm the designated nurse for Safeguarding Children for Northumberland, North East North Cumbria, ICB. So today, as I've been introduced, so I'm presenting the annual report from the CDOP panel, the Child Death Overview panel. Now this consists of Northumberland, North Tyneside, Newcastle, Gateshead, South Tyneside and Sunderland, and the work together via the North and South of Tyne Child Death Overview panel. And they are and they review the death of every child that normally resides in each of the areas, regardless of where the death occurs. And so this document, this presents the deaths that were reviewed between 2021 and 22, regardless of the year that the child died. And the panel did meet with about 8 times within that time frame, which is quite normal. It is a statutory task of this multi-agency panel to scrutinise the circumstances around each of the child deaths, and where appropriate to provide challenge to the agencies involved to further enhance the learning and the recommendations to appropriate agencies to improve service delivery and the patient experience. So what they're tasked with doing is to ascertain why the child's died through a thorough but proportionate review of the facts and the circumstances, and determine if there's any contributory or modifiable factors. So this can influence service, and we can identify if there's any risks or changes in services that need to be implemented. They would, like I say, they would make that recommendation to any of the organisations if this is identified. They provide data to the National Child Mortality Database, and they provide this annual report and contribute to the wider learning regionally and nationally. With the Child Death Overview panel, they're not commissioned to undertake public health campaigns or to deliver interventions arising from the learning from any reviews. Rather, it relies on its partners here in the Health and Wellbeing Board and in the Safeguarding Children's Partnership to incorporate any of the lessons learned into policies and to develop appropriate interventions. Have the next slide, please. So what I've done is I've pulled from the report, which I know that you have, because it does cover the whole footprint of the CDOP panel. So as you can see, the numbers in the red, that's for the whole of the footprint of the north and south of Tyne. So it gives you an idea of the total number of cases that were reviewed. So in the first sentence, there was, in 21-22, there were 19 child death notifications. but the total of deaths reviewed over that in this time frame were 10 for Northumberland. Now that's because it takes a while for there might be circumstances that influence when the death can be reviewed. So this is in particular if there's a police or a coronial process that's it hasn't yet concluded. So there was an increase in the child death notifications. So there was 16 the previous year for Northumberland, slightly up to 19. There was only 10 deaths reviewed compared to 20 the year before, but that could be because of other factors, if there's ongoing processes in place. Now, importantly, what I like to look at is at the deaths that were reviewed is, are there any modifiable factors that were identified? Grab the next slide, please. With how the report is pulled together and presented, it doesn't include the modifiable factors. So it was the same last year. I have to go back and find out what the modifiable factors, so we can get some meaning to that for our cases within Northumberland. And what they included over that time span were parental smoking, missed immunisations, service provisions such as delays in diagnosis or missed opportunities, maternal obesity during pregnancy, unsafe sleep arrangements, and failure to recognise vulnerability in young people. So because there's been a change in how the report is presented, grab the next slide please, what I've put in place is, because we really want to be identifying the themes as they're reviewed and any modifiable factors as they're identified. So I have linked in with the CDOP panel, and I am informed of each case in Northumberland when it's reviewed, what the modifiable factors are, so then I can be reporting back at an earlier stage to the Health and Wellbeing Board and to the Northumberland Children and Adult Safeguarding Partnership and across the wider health economy and in our partner agencies. So we're not reviewing, we're not looking at the year on after the report's published. So I have that in place. So like I say, every child death that's reviewed in Northumberland, I receive the additional information of the modifiable factors that I can share wider, and we can look for themes. And really, I think that's it. That's my final slide. I don't know if anyone has any questions.
Thank you very much.
Thank you.
Very brief presentation. Can I ask for questions? Yes. Jeff, Councillor Watson.
On page 27, on 5.4, the gender capital notification, are we just surprised by the figure of the difference between the male and female relationship of child deaths? In 2021, there was 35 male baby children died, and the year after there was 61, whereas the female went from 40 to 29. It seems surprising figures to me. Is there a reason why suddenly more male children were dying than female children were dying?
Yeah, I'm just looking for that on. I think must have a different page number to you.
5 point,
Yeah.
table 5.4, is that correct?
Oh, 5.4. Oh, sorry. Yeah, I've got that. I mean, I can't say without knowing what case is, looking what all the cases are, but whether the incidents, whether they're female or male, but that is that is an interesting factor, and like I say, that's across the whole of the CDOP footprint. They don't break that down into the Northumberland cases, but this is something that I can look into going forward.
Surprising as well? Can you find those figures surprising?
Well, actually, yeah, I do, and I don't know what they didn't give a reason behind that. Yeah, I heard there isn't a reason included in the report. There does tend to be more higher numbers within male deaths with infants. So I have noticed that, but usually a pattern nationally. But thank you for pointing that out, and I will
Yeah,
I'll go back to break that down.
Yeah, I think Jill, you want to make some contribution?
Yeah,
there?
thank you, and thanks for saying that you'll take it away and have a look at it. But it's just to note that obviously this is only 2 years, and quite often data can fluctuate quite significantly between 1 year and 2 years, but it's trend information that we want to look at over a period of time. So if you are going to look at it, it may well
Will
be
do,
worth
yeah.
looking over a longer period of time to see if it is a spike and therefore unusual, or if it is just more of a blip, as it were, because the data does fluctuate, because every death is really sad and unacceptable, but fortunately we are dealing with very small numbers, so it's quite difficult to look at trend information when it's such small numbers. And I think, again, just to confirm, my understanding is that there are more genetically conditioned factors that are associated with male babies than there are with female babies, so we do tend to see more very young deaths in the male gender compared to the female gender.
But thank you for pointing that out. You know.
That's a good observation, Jeff. Thank you. Alistair, you want to
Sorry, I didn't have a microphone. It's just one comment. There's an increasing trend for, medically, for very premature children who wouldn't have normally survived, counted as a child death, rather than, for example, as a stillbirth, which wouldn't necessarily have counted as a child death. Some of that helps the parents grieving and things, but there's a very great difference between a child who was born extremely premature, who actually realistically medically wasn't able to survive, and, for example, a child at term who had intrapartum complications, who died, which would traditionally need a full certain investigation. But just look at the numerical, there's an awful lot of these in the perinatal and neonatal period. And it's quite important, I think, to delineate between the two, because nationally we've seen an increase in child deaths, but that's mainly been not because there's been a physical increase in the number of child deaths by traditional definitions, but actually an increased way of very premature children often tell parents grieve where they're counted as a death, therefore it means that they were a person, therefore give them a lot more rights with burial and things. And I think it's important perhaps to delineate between the two, whilst I'm not trying to minimise the first. There are a set of sequelae that are very different from that, for example, from an intrapartum problem, or a child suicide, or a cancer, and I think putting them all together numerically kind of gives us a slightly different nuance, if that makes sense.
Yeah, because it does say that in table 5.2 it does have the highest percentages in the neonatal stage, in the first one. Yeah.
There are some that clearly, maybe as a result of something that happened during delivery, that should be counted as a very traditional child death, and there'll be some that will be extreme prematurity that probably would never have unfortunately have been able to survive anyway.
Paula?
Thanks, Chair. My name is Paula Mead. I'm the chair of the Safeguarding Partnership in Northumberland, and I think just to sort of point out to the Health and Wellbeing Board that previously the a few years ago, the governance for the CDOT annual report actually sat with the Safeguarding Partnership, or Safeguarding Board as it was then, and now it sits with the Health and Wellbeing Board. Although the partnership sees the report and actually takes note of it and make sure that interventions are focused towards it, I think what I wanted from today really was to highlight with the Health and Wellbeing Board that the governance does sit here, because with the modifiable factors, and actually it would be really helpful to have some sort of focused or be cited on an action plan of some sort around the modifiable factors. There are some things that we can't do anything about, some sit in the safeguarding arena, but the things like safe sleeping, all of the things that Jill will be very well aware of, actually I just would like that to be explicitly taken on board by this board. Thank you.
Graham, you want to say something?
Yes, please. Thank you. It builds on what you've just come in on. Firstly, I think we need to be careful that we don't become too detached from this report, because every child death is a tragedy to a family, and there'll be people in Northumberland continuing to be very personally affected by what we are discussing here. Secondly, I think if we go back to some of the discussions we had last time on family hubs, how we support families or how we identify people who are more likely to suffer these types of tragedies it is incumbent on us to make sure that all our services are taking that into account. The work that we're doing on inequalities, and what doesn't run through this report, perhaps as much as could, or maybe we should have a curiosity, is that each of these is looked at as an isolated event in a report, perhaps. And how much do we look at to see, are there groups of our communities who actually are much more likely? So we can see modifier risk factor of smoking or modifiable risk factor of obesity. But where are those clusters of people more likely to occur, or how can we impact on those people more? And I think that comes down to where the plan should sit. And obviously we're not going to generate all the answers now, but I think it is something that we should take away and take into what are we doing in family hubs, what are we doing in communities, how do we get people who are more likely to be smoking off the cigarettes, etc., etc. Yeah, thank you.
Any other questions? Yeah, please.
Hiya, my name's Ashley Eist and I'm the General Manager for 0 to 19 Harrogate District Foundation, and I cover Northumberland and Gateshead. I think it's worth just citing the Health and Wellbeing Board that from a 0 to 5 perspective, health visitors universally do that really comprehensive family health needs assessment that commences in the antenatal period in partnership, with the system, but also it's built on from, a new birth to a 6 to 8 week, and incorporate into that assessment is a tool called the Home Environment Assessment Tool that explicitly works with parents to look at sleeping habits, risk factors around safe sleep. It's built on, there's action plans built into that, that analyse risk and try, to put a safety plan really or to escalate risk around a child.
Thank you. I just have one question, maybe based on what you just said. We have this modifiable factors presented to us, like parental smoking. Which one is more significant? Are they equally likely, or should we be focused specifically more on something?
I think risk is risk, and we need to really comprehensively look at all risks in the context of the family.
Okay.
I mean, when our family health needs assessment's really robust, it looks at things from parental smoking, parental relationships, safe sleeping, attachment, it does a real comprehensive assessment around significant others within the family, perinatal mental health. So it's about really that really robust holistic assessment on the entire family.
Yeah, I understand that in a family context, but at the global level, or at least at the county level, what we should be more concerned about, like child immunizations, for example, missed immunization.
Yeah. I mean, I'm relatively new to Northumberland. I think I'm day 5, so I'm really trying to get underneath the data. So, that's something that I can take away and have a little bit of a look at and bring back to the board.
Yeah, for example, missed immunization, I mean, that's a completely avoidable thing, isn't it? I mean, what we are not doing is that this is becoming a factor, so that would be a very interesting insight into what we need to do in future. I mean, as a county, as a board, yeah. All right, thank you. Yes, please, Jill.
2 brief points. First of all, to go back to Paula's point, just to reassure, we've actually shared the CDOP report with our tobacco partnership to make sure that they can actually pick up on this and are very cited on the fact that this is real life happening and in tragic circumstances. So that's one. And also picking up on the point around family hubs, we're delighted that in Northumberland that our registrars is based within the family hubs, so we can do a wraparound holistic. So if people are having to report the death of a child, then they're within that situation of an environment where they can seek further support if they haven't already taken it up from the hospital, for example.
Yes, please.
And Jill will be able to confirm this. I think Northumberland actually does pretty well with childhood immunisations, and our rates have always been, I can't speak for the last couple of years, but they've always been actually really good compared to the national average, for example. But there's that one case perhaps that, falls through that net.
Yeah. Yes, please.
I'm Julie Snowden from the local medical committee. Can I ask, are families informed if their child's case is being reviewed?
Yes, because when the child dies, we are given a lot of information around the support and what the process is, and part of that leaflet and the information that's given verbally is that there is a review process. Yeah.
And if that review shows that there was a modifiable factor, for example, smoking, is that, I can imagine as a parent, and if you're told smoking cessation was, or smoking was a modifiable factor, there'd be a lot of guilt around that, and what support is given to
It's not fed back to the
Right.
parent because, especially that, because you would, it has to be proportionate and relevant, and it's the whole process. I think of the CBDOP is the learning to what we can do wider across the service, because especially that, because the grief and the guilt, it would, that sort of blame and sort of, that's avoided, and it's done as a supportive measure.
And are the actions fed back? Because if your case is being, your child's case is being reviewed, you would like to think that some action is resultant to make sure as far as possible that other families don't go through that.
It's not fed back, no, not that I'm aware of. It wouldn't. So, for example, if it was co-sleeping and the parent had been under the influence of alcohol or had been smoking, that's something wider that would be, you know, would look for trends and patterns if there had to be, you know, some support put in or in, you know, to raise the awareness and to reduce the incidence of it. That wouldn't be fed back, because then that would make the parent aware that that factor that was influencing. I mean, the whole process behind the CDOP is to look at the wider picture of the learning that can be done to prevent, you know, these deaths or incidences occurring. So, yeah.
Thanks.
Yes, Wendy.
Thank you, Chair. It's a question for Graham, really. I'm a bit out of practice with pregnancy. I just wondered, when someone comes into the surgery pregnant, what is the system now? Are they handed straight over to a midwife? You know, are they, if you like, given every bit of information regarding the child, and what is the system?
Yeah, there's two routes now, really. You can, as a prospective parent, self-refer directly to the midwife service. So some people will become pregnant and refer themselves directly, so they're immediately on, and that's through the new Badgernet system, which is a new IT system which has been used. Alistair, from a Northumbria perspective, might need to add detail, but that's my impression of how that works now. If somebody was to come to the surgery, we would do what is required in terms of double checking that that person is as healthy as they can be for the pregnancy. So we would automatically identify some of those things and put them in touch with smoking cessation at that point if needs be.
Thank you.
Alistair?
Just for clarification, the Badgenet's now a regional maternity handheld patient record that all women use. It's on their smartphones, and there is provision for women who don't have a smartphone to get one, but the take of that's very low. It has all of the health promotion, etc. at the fingertips, and the evaluation of it's been very, very positive with women in compared to what was previously the handheld record. So it has a full set of the health prevention, health promotion things for them, really from probably earlier than they were previously getting, and increasingly women are self-referring to that, and they actually get the app automatically as they self-refer through to the midwife services.
Thank you very much. That's interesting to hear that.
Yes, Graham, you want to come in?
Yeah, I think just to capture what Graham said, I think what I'm feeling is the sense of what needs to come away from the board and what needs to be thought about with regards to whole systems approach. So I presented, and I really enjoyed your presentation, and I think the content of the report is significant. I presented to the board in October about a collaborative approach to safety and well-being. That's predominantly in a home environment. From that meeting, I've got my first meeting with Harrogate and District, I think on the 23rd of January. So that's looking at that approach with regards to young people. We're now also part of the Tobacco Control Partnership. So we're maybe often seen as a small part in the bigger machine, but what Fire and Rescue Service have is a very unique brand to get across a door threshold that maybe is sometimes challenging. So I think it's not so much a question, but a statement of our intent when we sit at the front of this chamber and sign a compact as to how we will commit to delivering our services, this very much should be a focus for what we do take away and what we continue to commit to the way we actually deliver the services, not just the way we strategise.
Thank you. Thanks. Any further questions, comments to Alison? Yes, please.
I just wanted to ask, on table 7.1 in the Northumberland, the percentage with modifiable factors of deaths is significantly higher than other areas in the region. Is there any particular reason for that?
I'm just getting that. Yeah, and I know Sunderland's high as well. Yeah, in Northumberland it is high. That's why I was wanting to really come here to present this and see what my action is, because I want to be breaking this down to see what exactly are the links, you know. So I think what I'll take away from today is not what I'm planning to do is, you know, to find out actually live as they're being reviewed, the age of the child, what the modifiable factors are, but also I think I'll find out what area within Northumberland they are. So we can look to see if it is something like parental smoking or co-sleeping, if there's you know, more learning that we can find to target there. But they have, and I think the previous year as well, they were fairly high, the 45% the previous year with modified factors, in 60% this year. So we do have high numbers, have acknowledged that, yeah. But it's really need to break down to find out exactly what those modifiable factors are.
Yes.
Can I just add, I think you have to be careful with interpreting that, because although it's if I remember rightly, it's 60% or 6 out of 10. So if you say 6 out of 10, it feels very different to 60% modifiable factors are there. And it's just the numbers are so small. And I think that just needs to be sort of understood, really.
I just want to absolutely agree with that. It is, every death is tragic and horrendous, and that's why we look at them, and this is about presenting future deaths. Yes. The numbers are incredibly small, thankfully, so percentages can skew our perception of things in this.
Yeah. But still, North Tyneside has 1 out of 10, so it is, you know, relatively speaking, there is something here. The data is telling us something about Northumberland, so it is a matter of concern, I think, as someone expressed. Yeah, we need to look closely into that one.
I think that's it. We need more, you know, kind of tangible information, evidence, so that I can bring back, so we can look into that. And just go from the lady at the front there who had asked about what services are put in for women when they're first pregnant across Northumberland, is system-wide within health. And I have a colleague, Ashley, here from Harrogate. You know, we've implemented a lot of health promotion. One in particular is ICON. That's been rolled out nationally, but it is very embedded within Northumberland across midwifery services, 0 to 19s and in primary care. And that's to raise the awareness and reduce the incidence of abusive head trauma, so shaken baby syndrome, and that's delivered alongside Safe Sleep, and that's across the board from the midwifery 0 to 19 and within primary care with parents as well, so about, you know, not co-sleeping and not to sleep under the influence and smoking. But an area that I'm very interested in is the impact of parental vaping and how that, there's very little evidence about that. We know about the impact of smoking on child death and the increase of sudden infant death from smoking, but there's not a lot of evidence with vaping, so I'm linking in with the Public Health Registrar to look into that.
Thank you very much. That's really interesting. It might be something we could discuss in future, Paul. Yeah.
Sure.
Thank you.
Sure. Yeah. Well, if there are no further questions to Alison, thank you very much for coming and making your presentation and asking all our hard questions. Thank you.
Could I just summarise, Paul?
I'm sorry.
No, I just think, just to labour Graham's point here, I think as a summary to this part, it is incumbent on everybody that is here to go away into their organisations with this report in mind, and then ensure that their organisations work into the partnership around children and young people to the best of their ability. So our strategy is the Children and Young Persons Partnership, which is actually should have the solutions to this, as long as all the partners consider these factors and take that away. I think it's just incumbent on a sense of responsibility of people in the room, really. Yeah.
Thank you. Thank you, Graham. That's a real good summary. Now we will move on to the item number 5, annual report, safeguarding children in Northumberland. And Paula Mead, you are going to... Whichever is convenient to you. Okay.
Graham's will kick off with sort of an overview, and then I'll
Yeah.
talk through the report.
Yeah, just confirm, I'm Graham Wright, I'm the Service Director for Children's Social Care, currently the Interim Director of Children's Services. And just to give the context for both the next two agenda items, both the Children's Safeguarding and the Adult Safeguarding Partnership in Northumberland, we are currently integrating the adults and the children's safeguarding partnerships. Now, they're both underpinned by different statutory and legislative guidance, but in Northumberland, the partners made the decision that we could add value by integrating the partnerships, make for more effective learning, as well as streamlining and working more efficiently. So we're currently in this financial year going through the process of integrating the two partnerships, and we will have a structure and a model for the next financial year going forward from April. And the important thing is that these are partnership reports. This is about the safeguarding of children and about the safeguarding of adults. And the two reports here are done separately. In future years, they will be done as a combined report, but obviously focus on the relevant separate sections, given what the differences are. But as I say, the point of us integrating those partnerships is to develop and enhance the learning that we can get and the assurance and oversight of safeguarding practice, and also perhaps develop our workforce more efficiently. So in terms of the detail, I'm going to pass to Paula first to look at the Children's Safeguarding Partnership report. Paula is the independent scrutineer and chair, and will give an overview of the range of information that's contained in the report. And obviously we can take any questions then, and then we can move to Karen will present the adult safeguarding report.
Thank you.
Thanks, Graham. So it's a bit of an odd sort of year because an annual report normally runs through a financial year. The reason this is different is because the new arrangements for moving from children's safeguarding boards to safeguarding partnerships happened in September 2019. So this report runs through that period of time. It's just a bit of an anomaly, but that's how it works. As Graham said, it is a sort of collation of information that the partners have provided to make up this annual report. So there might be some things that I can't answer immediately, but I'll do my best and certainly find out if there are any questions that we can't answer. So it really sort of it's intended to demonstrate the effectiveness of the safeguarding system in the area, and how, if we work together, the added value that a safeguarding system of working together makes a difference to the outcomes. But also, if there are areas for development that we haven't maybe got right over that period, that they need to be explicitly mentioned in the report also, and therefore what we're going to do about that. Overall, I would say my conclusions in the report, based on the data that's been provided, both quantitative and qualitative data, which you can see in the under the priorities mainly, Northumberland is working effectively by and large in terms of the way that we're working. The partnership, the safeguarding partnership, is an effective safeguarding partnership. There's a great deal of goodwill by the partners to work together and to be open, transparent, and make sure that children and young people's welfare actually is at the heart of all we do. I think some of the improvements that we've seen over the last year have been work around the voice of the child, and I hope that comes through in the report, how much work has been done to incorporate particularly vulnerable young people's voices into the work that we do, and how we actually take that on board and what we do about that. So, as Graham said, it's been a bit of a transitional year, and although the report deals specifically with children this year, some of the aspects of that transitional year has been that we've got a number of priorities which probably, well, will be reviewed in the next sort of few months. They've been priorities for a while now. The overarching priority, which you can see, has been the impact of COVID-19, and that actually has continued to sort of amplify safeguarding concerns and risks to children really over this last year, mainly around having eyes on those children and young people. That's been one of the issues, and around school attendance and so forth. So, as I say, it affects probably all of our other priorities, which include mental health, which also includes suicide, self-harm, and the impact of social media, and the workforce's capacity to actually meet and address some of these concerns. Neglect continues to be an issue in Northumberland, not just in Northumberland. It is particularly an issue, I think, in the North East. It's one of those very broad sorts of harms that we continue to be worried about, really. There's been a lot of work done around that. There was a neglect summit attended by all the partners in May, and there's a lot of work going on at the moment to address that. However, the socio-economic environment that we're in doesn't make that particularly easy, although neglect can impact on all social groups, actually. But in terms of pressures, clearly, if people are under stress and pressure due to their socio-economic situation, then that's a factor. We've been looking at safeguarding children under 1 because they're the most vulnerable group, and again, for obvious reasons, that's been something that we've had our eyes on as a result of probably some serious case reviews that we've had in the past. The impact of domestic violence on children, again, that COVID's had an impact on that, and also child-to-parent violence and abuse. And finally, although harmful sexual behaviour hasn't been the stated priority as such, that is something that we've done quite a bit of work on over the last year because of really sort of horizon scannings and looking for risks that are coming at us really in the future. So that's something that that extra familial harm is something that we probably need to really take a good look at going forward. So previously, we had a thing called serious case reviews, where each case was reviewed that met the criteria was reviewed, and a report provided with lessons learned and so forth, and action plans put in place to deal with those. That's changed now to what are called local children safeguarding practice reviews. I always find that hard to say. But the purpose is the same, although the process has changed because now we do rapid reviews, which actually may be sufficient to learn the lessons that we need to learn and to put things in place that we need to put in place. So there's been 2 rapid reviews over the last couple of years, the last year, due to suspected child suicide. They didn't meet the criteria for the more formal children's safeguarding practice review. There was one learning review where neglect featured, and there's an action plan being monitored with that. And there was a recent domestic homicide review in Northumberland where a young person was involved, and we've been taking note of that, and although it's under the remit of Safer Northumberland, the aspect in terms of the young person has been brought to the Safeguarding Partnership. So I think, as I say, all in all, the data and the analysis in the report demonstrates, I believe, that Northumberland partners have worked well together. They've met their statutory duties and delivered safe and effective services that do their best to safeguard children. There's always issues that arise within the safeguarding arena that come at you. However, it feels that the system is as safe as it can be, and there is some evidence of improvements as well going forward. Thank you.
No? Yes.
I just want to say thank you very much for such a comprehensive report. I do get involved in the safeguarding element through the ICB at a local level, and the information that's brought forward and the processes that are in place do seem to work very well.
Thank you. Thanks.
Thank you. Okay, I have well, one question because nobody seems to be asking any question. You know, recently we all came across a television news where a child died because the council completely neglected the living conditions. So, of course, it's very embarrassing for the council, and I would, you know, I wouldn't like to see that here. So these agencies have the remit to review all these cases, I assume. So what is our situation in County Northumberland that things are under control? Because here in page 79, you are saying what we are worried about. Poor mental health, living conditions. So do we really go monitor living conditions, especially in the social housing sector? Sorry if I asked a very...
No, it's a big question. I suppose, I mean, well, I think the manager from Harrogate sort of did intimate that the health visiting service, or the 0 to 19 service, is actually a universal service.
Yes.
And I wouldn't want to use the word monitoring because,
yes,
you know, we're not here as the sort of safeguarding police, if you like. We're here to identify risks and to help and support families, you know, to manage those situations. So there is a very comprehensive, as I understand it, assessment of families when the health visitors visit, both antenatally and then when the child's, I think it's 2 weeks, 14 days, 10 to 14 days, something like that. And so, you know, every child will be assessed or family rather, not child, would be assessed in that way. I mean, for older children in terms of universal services are really important. Schools, absolutely fundamental in terms of, you know, having eyes on children and families. They're key partners in terms of the partnership. GPs practice, you know, GP practices, again, absolutely important factors in terms of our safeguarding arrangements, again, trusted professionals. So there's not one simple answer to that question, but education of staff, safe and understanding what safeguarding is, the risks associated with that, and empowering staff to raise issues, A, with families if possible, or B, with you know, the safeguarding system, with children's services if necessary. So they're all sort of part of the whole picture, if you like.
Yes.
Obviously, I can't comment on individual.
Yes.
You know,
Yes.
sort of
The reason I asked this question was because when I was going through the case in the television, because the parents of the child approached various agencies about the problems, but they were neglected. So it looks like there have been, well, I don't want to be judgmental, there are faults at many levels, so I just want to make sure whether this comes under the remit, and it looks like the answer response you gave is pretty...
But you're right, actually.
Yes.
And I think Graham will be able to say something about an audit that we did around, you know, listening to families. I'm not quite sure which case you're talking about, but it may be one of the high-profile cases that we've seen recently. And so we did an audit, didn't we, around how we listen to... Well, Graham will talk about, because it was a children's services audit.
Sorry, Jack, can you just be clear which national example you're talking about?
Is it Roach?
It was the one where mould was found.
Okay,
yeah, the mould was that. That's right. Yeah, the whole social housing walls were full of mouldy. Yeah.
And I think that's right. And I think that's a discussion also which we've had with housing colleagues around that. And one of the responses to that is to ensure that all our staff, when they are visiting families, and if they see areas of concern around the state of the house, what we actually know what to do with that.
Yes.
So it would just be part of our overall duties, but if we see that, one of the things we're developing is the guidance so people understand in detail where they need to go to ensure that there is a response when they find that.
Thank you. Thank you. Thank you very much. Yeah. Yes, please.
Claire Wheatley, the superintendent from Northumbria Police, would normally be here, but she couldn't today, so we did ask her to comment on the papers. So just for the board, she sent an email which I will not share, but I'll read the beginning of it because I think it just gives us some assurance from her perspective. Bear with me. The reports contained within the papers give a good overview of the safeguarding boards of which Northumbria Police is a key agency and work alongside of ICP and local authorities to achieve the priorities set out within each safeguarding board. Northumbria Police have a dedicated safeguarding department to support the safeguarding boards and safeguard children and vulnerable adults through early intervention, prevention, protection and pursuit of offenders. Safeguarding is everyone's business and all police officers and staff have regular training to recognise vulnerability and safeguarding concerns. Okay, so she has commented. I'm sure if any of you wanted to raise any questions, let us know, or we could ask at a meeting when she can attend. Thank you.
Okay. Thank you. Oh, yes, please, Graham. Yeah.
Just to confirm that, and I think that the point about safeguarding being everybody's business is absolutely right. And I think one of the strengths of the partnership is that we're open to challenge within the partnership. You know, there are some difficult conversations that are held between professionals. There's a couple of things sitting in my emails as we speak around responses that social care have given, which is absolutely right, for that challenge to happen, to make sure we make the right safeguarding decisions. And that is a key part of, I think, of the culture and the practice here. And whilst we'll never, ever be able to guarantee safety, I think the systems and culture and practice that we have in Northumberland is positive around that.
Thank you. Okay, so shall we move on to the next item? If there are any questions, item number 6, same safeguarding report, but this time it's about adults. Yeah, thank you. Karen.
Good morning.
Yeah.
So my name's Karen Wright. I'm Senior Manager for Strategic Safeguarding Adults, and I'm the author of this report, but as already noted, this is a safeguarding partnership report and is contributed to by a number of agencies. And this report meets one of our statutory duties. So as a Safeguarding Adults Board, one of our statutory duties is to prepare and publish an annual report providing detail around the board's activity and how we are safeguarding what used to be referred to as vulnerable adults is now referred to as adults at risk. So the report describes the work of the board that's was undertaken during 21 to 22, and it provides information about data, about improvements that have been made across the safeguarding system, and it describes how we've responded to our key priorities. So in terms of the data section and just in terms of some key highlights, what I can say is that we have, as we've reported in our last annual report, we've continued to see increases in safeguarding adults activity, which has been COVID related, but we continue to see the impact of COVID in terms of particular surges around safeguarding adults activity, particularly in relation to things like self-neglect, isolation, mental health concerns. So that continues to be a theme, and domestic abuse as well continues to be a theme. So the report tells us that we've seen a 38% increase in safeguarding concerns. However, that is lower to the what we reported in the previous years. And within the data, within the COVID section, there is a really helpful graph which plots the surges, which were clearly related to COVID, periods of lockdown, and then coming out of lockdown, particularly in relation to domestic abuse. So there's a helpful graph there, which is based on the national data. So we've also seen a 6% rise in safeguarding inquiries, which are our investigations. And the main location of abuse was people's own home, and that tends to be a trend year on year. However, we have seen an increase again in residential and nursing homes, which during COVID was very absent, as you can imagine, because obviously those services were closed and to visitors. So we had to think about quite innovatively how we kind of monitored the care within that provision. But we did see less reports during that time. But this year we've started to see increase as more visitors are going into care homes. But we have done quite a large piece of assurance work around closed cultures and around how we monitor those environments using all the agencies within the Safeguarding Partnership. And it was certainly included on our SAB risk register during COVID. So a key focus for the board this year has been understanding the impact and the legacy of the pandemic, which has enabled us to really identify some of the themes. I think one example of that would be we've done a lot of targeted work around self-neglect. We've worked regionally with our colleagues across the footprint, particularly around self-neglect. We've launched a public awareness campaign. We've produced an animation and lots of practitioner guides, and that's been directly informed by lessons learned across the footprint and also nationally. And what is I think a key strength in Northumberland, and it has been since its initiation, is the MASH. The MASH works really, really well in terms of providing an effective multi-agency response, and that's an all-age response. And I think, you know, we've highlighted that in the report, that continues to be a strength, and that strong multi-agency working at the front door, and it enables us to act quickly in terms of safeguarding concerns. So the report goes into quite a lot of detail around the 5 current key priorities of the board, and as Paul has said, as we've become an integrated board, at the beginning of the financial year, when we have the final model, we'll be reviewing our priorities, because clearly there are some that will go across all age, and that think family approach, but then there's also recognition within the new board arrangements that there is also the value of keeping something separate, and there's a reason for doing that. So there'll be some priorities that are either adult or children focused only, but there will be that strengthening across the all age issues. So our priorities are obviously being around the impact of COVID. Transitional safeguarding is a real strength in Northumberland, and the work that we've done in terms of transitional safeguarding has been recognised nationally. We've been asked to speak at webinars and talk about the Northumberland approach. What I would say is we haven't got it absolutely solved, but we've started the work, and yeah, it's a journey, but what we have done in terms of a protocol, workshops, audits, has been recognised as good practice. So I think that's a key strength in Northumberland. There's a section on domestic abuse in terms of all the work that's taken place around there. We obviously, the last annual report, the increase in domestic abuse was of significant concern. There has still continued to be, I think it's a 36% increase in domestic abuse this year, but that's much lower than last year, which was particularly high. And it continues to be a priority for both the adults and the children board, and we anticipate that will continue to be so as a joint integrated board. Criminal exploitation, we've had some local operations, but we've got a really strong strategic exploitation group that works across children's ADS partnership, but also the community safety partnership, and we have a delivery plan looking at community awareness, disruption, and a range of things. And the final one is around making safeguarding personal. That's always a priority for the Safeguarding Adults Board, how we hear the voice of the adult. We are really strong in terms of our data around asking adults at risk around what they want to happen and achieving their outcomes. What we're less strong on is involving the adults at risk in the work of the board, and that's a key priority moving forward about how we do that. And within the new arrangements, there's a communication group that's going to look specifically to make sure that we do hear the voice of the adult and the child. There have been no safeguarding adults reviews this year that have met the criteria. However, we have commenced 2 learning reviews where, so under section 44 of the Care Act, we still have the discretion to undertake a review even when the safeguarding adults review criteria is not directly met, but where we think there is significant learning for agencies. So we have commenced 2 learning reviews. And we've finalised a joint learning review with children the Children's Partnership around a young man who took his own life. And there's been significant learning from that, but there's also been, and that's not just in terms of where we need to improve, there's been significant learning in terms of good practice. So we're trying to, we're going to showcase that with some appreciative inquiries, because we feel strongly that it's important to learn from what we do well as what we don't do so well. And as Paula mentioned, this will be the last annual report. So for the last, since trying to think since when we've been a joint board with North Tyneside ever since I've been in post, which is 5 years. So yeah, we've been a joint board with North Tyneside, and following a independent peer review, it was decided by both areas. It was, and I think COVID helped us see that there was an importance on focusing on place-based arrangements. So we have now separated from North Tyneside, and obviously we're integrating with the Safeguarding Partnership. So this will be the last report in the form that it is. So I hope that was helpful. I'm happy to take any questions.
Thank you very much. It was a very informative report, both of you. Thank you. It's time for questions. Do you have any questions? Yes. Wendy.
It's not a question, Chair. I just wanted to say thank you to the safeguarding team. I can't tell you how important safeguarding is. The council take it really seriously. And we have a wonderful team, and Paula is excellent as our little moderator. I don't know what the word is for you, Chair. Well, but we're very grateful. Thank you so much.
Yes, please. Yeah.
Hi, my name's Julie Boyack. I'm the voluntary sector rep. I just wondered, is the voluntary sector representation on the partnership board?
There is on the wider partnership, yes. So in terms of the structure currently, there is a wider partnership where we do have voluntary sector representation, but then on, for example, the strategic exploitation group, we also have the voluntary sector on there. But one of the things that we are currently doing is reviewing the membership for all the subgroups, because we have a new structure. So we're going to make sure that all agencies are represented, but they're represented on the most useful groups to them. And I think what we have done is a bit of analysis, because there was some concern that some agencies might, the demand might increase. So to make sure that, that we're not placing too much demand, but certainly the voluntary and community sector will be a strong partner in the arrangements moving forward.
Just one thing, question for me. You mentioned about self-neglect, and obviously these voluntary sector organisations will have thousands of volunteers working in Northumberland, and I just wondered what training would be available around self-neglect and identifying it, especially if someone has capacity who are working with and just choose to live that, and when it becomes a safeguarding issue, that would be if there was some training.
What we do have is, obviously we have a Safeguarding Adults training programme. We have lots of guidance documents, but what might be really, really helpful is the animation that we've recently produced. So it's aimed at the public and volunteers, and it's essentially how to recognise self-neglect. We've also produced some seven-minute briefings on every aspect of self-neglect. So that might be really helpful for volunteers. So I'm happy to send them, or they are available on the Safeguarding Adults website. But I think they're some really, really helpful guides. What we've learned from learning reviews is that although we have a comprehensive self-neglect guidance document, we found that actually staff either weren't aware of it or they didn't read it, because they're very busy and they don't have time to read a 30-page document, which is why we produce the self-neglect guide. So, for example, there's one on hoarding, there's one on alcohol, there's one on self-care. So depending on what you're concerned about, you can quickly just go to that guide, and then there's links and contact.
I wasn't
people.
aware of that.
So if you have any problems accessing them, I'm happy to send them to you directly.
Great. Thanks very much.
Thank you very much. Are there any? Yes, Jill, I thought you would come in.
Thank you.
Thank you so much for the report. It's really informative, and whilst I'm very familiar with children safeguarding, less so on the adults, so I found it really comprehensive. Obviously, as you come together as children and adults, one of your cross-cutting themes will be domestic abuse, and I know you've done a huge amount of work, haven't you, recently on the domestic abuse partnership. I'm just wondering, from a governance perspective and the link to the Health and Wellbeing Board, and is there an appetite for the board to receive an update around domestic abuse, whilst it might not necessarily be on our forward plan, or would that be duplication, because everybody here is already on the domestic abuse partnership? What's your reflections on that link, Graham?
I mean, as part of this, we're looking, as Jill knows, the wider governance as well, to try and streamline and maximise the work, because there's so many different governance and oversight arrangements. So that certainly is part of it. And so, for example, I'm chair of the Domestic Abuse Local Partnership Board, and whilst it clearly is a priority here, how we maximise the work and the links is something that we need to keep evolving and developing, I think, to make sure that we don't duplicate and we can work more effectively than we have been doing, I think. I think that answered the question.
Thank you. Yeah. Shall we move on to the last item? Eighth item. No, it's the seventh. Sorry. Last major item. That's what I was going to say. Better Care Fund and Adult Social Care Discharge Fund. I think Rachel or Neil or both are going to do it. Thank you.
Thank you, Chair. Yes, I'll start off, if that's okay. This is a slightly unusual report in that I'm coming to ask the Health and Wellbeing Board to endorse and sign off two facets of funding here, the Better Care Fund and the Hospital Discharge Fund. But we actually started spending the Better Care Fund on the 1st of April 2022 and the Hospital Discharge Fund in mid-December. So it's not an ideal situation in terms of signing off that far on, but I'll explain a little bit the context of that as I kind of work through the report. Just as a reminder, and for those who aren't aware, the Better Care Fund started in around about 2015. In fact, not around about then, it started in 2015, with local authorities and CCGs at that point in time asked to amalgamate certain budget streams from a pooling perspective. And I think the intention really was to force CCGs and local authorities to work more closely together in terms of planning health and out-of-hospital services within their areas, which was a really good motive. We were lucky in Northumberland, and we were cohabiting with our CCG at that point in time. We had excellent relationships then, and we've continued to have excellent relationships with the CCG. That wasn't the case in every other part of the country, so I think the merits of what the government was trying to achieve with this were good. Whether it worked or not, I think case by case, there's different outcomes to that, but it certainly hasn't affected our relationship, and we've continued to have a really good relationship going forward, and the BCF has been a core part of that moving forward. The difficulties start to arise with the BCF because we are required to comply with national guidance, and that national guidance is normally issued about 7 months into the financial year. So you have to start spending the money on the 1st of April, and the guidance doesn't normally arrive till 7 months later. That guidance sets out certain metrics and things like that that have to be reported back to government in relation to the BCF, and the CCG and now the ICB have to get their processes in place to do that. It came a little bit earlier this year. It came in late July, which is still far too late in essence for it to have any meaningful impact on what you're planning to do as you move into a financial year before you start to spend the money. With a requirement to submit a plan towards the end of September. So that didn't leave enough time to come through Health and Wellbeing Board between receiving the guidance in July and actually needing to do the submission in September. So as has been done in previous years, this isn't a new thing this year, the plan was agreed at officer level and in essence had been worked through since April anyway. Discussions started at an earlier point in the year, and the intention was always to come again for ratification to the Health and Wellbeing Board at a later point. The government announced in September as well, though, that there would be a hospital discharge fund, and that would be included in the BCF, so it became pointless to come to the Health and Wellbeing Board straight after September because we knew we'd have to come straight back to you again a month or two later to deal with the hospital discharge fund, which we didn't get any detail on until toward the end of November. So we got the allocations at the end of November, and we actually got the detailed guidance on how that scheme could actually be utilised not until early December, with a deadline of the 16th of December to submit a plan back. So again, we had less than a 2-week turnaround to actually put the plan together with ICB colleagues, and we involved the Trust in those discussions as well, because clearly the Hospital Discharge Fund, there's a key interface with the Trust there around what they achieve out of it. Again, no time to bring that to Health and Wellbeing Board. So what you've got now is a consolidation of issues that we've had to tackle at officer level with colleagues where appropriate, and we're now bringing it to you for ratification. I will run through that in a little bit, the detail of that a little bit more, but I think one of the points for the Health and Wellbeing Board to consider in here is whether you want us to have a look at process in the context of that. And I have to say, I can't see an imminent prospect of that process changing. I think we will get guidance late in the year again next year. But is there anything the board would like us to do to try and get more inclusivity and involvement at this point in what's actually happening? If I touch on the section 1 of the report first, which is the Better Care Fund, there's a very brief couple of paras there. I mean, what I would need to stress with the Better Care Fund is, at its inception and as additional elements have come into the Better Care Fund, this is recurrent funding unusually. I mean, often what we get from government is one-off funding, which we have to try and dispose of, as the Hospital Discharge Fund is. It's all got to be spent by the 31st of March, and that will therefore be on discrete, short, time-limited schemes. The Better Care Fund itself is not that, and the inception of it was not that. It was pooling of recurrent funding, and what has gone forward is recurrent funding. So what we spend it on is entrenched in core services, which means we're actually quite limited on what you can do with it at this point in time without reducing core services somewhere. So from a local authority perspective, a large amount of the Better Care Fund goes into domiciliary care services, and as a result of the pressure in domiciliary care services, some of the growth that we've had in the Better Care Fund this year, and we agreed with the ICB, and proved to be quite prophetic, to be honest, was we stuck £500,000 into the hospital discharge team, and we grew that team quite significantly, which has actually meant that, and Rachel was telling me yesterday, Northumberland's been able to outperform a significant number of regional colleagues and national colleagues in terms of our ability to get discharges through in our relationship with Northumbria, which is fantastic. But again, its officers responding at that level, and I'd be interested in whether the Health and Wellbeing Board has a view on whether we can do anything different with that. The Appendix A sets out the monetary detail of where the Better Care Fund is actually spent across the different components, and it's split into 3 sections. So the first section is the core funding that comes via the ICB now, formerly the CCG, to the council, and where we actually allocate that to adult social care services within the council. There's then a second section, which is the Improved Better Care Fund, the IBCF, which was an additional stream that came through about 2 years later, about 2017, I think it was. That money comes direct to the council. It does not go through the ICB or the CCG, but we're required to plan with the ICB on how we use it, and that has happened at the point that that went live, and you can see within there where those large chunks of money are actually going into core council services. Again, I would re-emphasise, if we wanted to change that, that will have an impact on core services that we're supplying at the minute, which is why we are fixed to a degree in what we do at this point in time with it. And then the last element of the tables at Appendix 1 is the ICB's own part of the BCF, which it allocates towards predominantly community services, community nursing, I think, and community hospital services. But Rachel can comment a little bit more on that if there's any questions on that when we get to that part of the discussion. We've also attached the narrative report which the ICB do, which was submitted with the plan. And as I say, people can digest that and have a look at it, and hopefully they have done in the run-up to the meeting. The part 2 of the report covers the Adult Social Care Discharge Fund. So clearly there was a real race on to get plans together to try and come up with ways to use this effectively. Clearly the biggest problem we've got at the minute in social care around discharge is capacity in the workforce. And given us a grant that we've got to spend in 3 months with a couple of weeks' notice to plan, does nothing really to help us with that fundamental problem of workforce in adult social care when the funding does not extend beyond the 31st of March. So we have tried to be pragmatic in what we've planned with the ICB and with the Trust in this, and we have gone for schemes that we think will deliver something over that 3-month period in that short time span. That said, the guidance did allow us to do things that would solidify the workforce, although we didn't think we could grow the capacity of the workforce. So one of the largest component parts of the use of the discharge fund will be to bring forward the real living wage pay award to carers working within domiciliary care and residential and nursing care, where their component providers and companies sitting above the providers are happy to do that. We will fund that pay award being brought forward to a point in December that we've agreed with those providers. And I'm still waiting for the first set of figures through on take-up of that, so that's already started. And again, the intention there is to stop the leakage of people out of the care system into other sectors, because there are a lot of jobs around at the minute. We're in competition with the market, with supermarkets, with pubs, with restaurants, etc. And there's a draw from different areas to there. So that was the big part of it. The other component parts that we went for, we are looking at More flexible solutions for dom care support. We're looking at a couple of pilots with providers around a model that has been tried down in the London area and down south as well, whereby we don't stick with traditional rotated care for people. So normally, you know, your carer goes in between 9 to half 9 to assist you to get up and get ready in the morning. They go back at lunchtime to help you to prepare a meal, and they go back for an hour in the evening to get you settled for bed, whatever. We're looking at bringing together cohorts of carers with cohorts of clients and having a more flexible solution to that. So the carers and the clients link up, and the carers are more on call to the client, and they move between that client group to try and offer a more flexible service. Because actually, you know, if you're not feeling like you want to get up at 9 o'clock in the morning, can we flex that a little later? So there's some attempts at that where we think we can cohort more people because we offer a flexible approach. So we're going to trial that through it. That's a little bit more innovative and great. Some of the other things we're looking to do around this are things like looking at live-in carers, looking at using it for bespoke packages where transport is a big issue because we can't get care out there and it's normally been a limiting factor. So we're going to use the grant to meet those transport costs in the short term. So kind of more traditional options, but that have been without the parameters of what the council would have normally funded and have the budgets to fund at that point. So the next one was equipment. I mean, another delaying factor for getting people out of hospital can often be getting equipment into the home to get them back home, and specialist beds are a key thing. So we're both buying specialist beds and stockpiling those at Cramlington so we can move much faster and get people back into the home quicker, and we're not waiting for delays in orders. Even if that's 24 or 48 hours, that can be quite significant for the trust. So getting them out 24 hours earlier frees that bed up. We have block booked some beds in care homes. I have to be brutally honest, it's not something I'm a big fan of here in Northumberland. I don't think our geography suits it, but I know it gives some reassurance to the trust, and it does get that capacity held for people coming out of hospital. So we have done a small amount of block booking which is being used for beds, and we've block booked a couple of dementia beds as well out of area because there isn't a significant amount of capacity in Northumberland, but that's often a problem area for discharge where people have complex challenging behaviour. You can't put them in a mainstream residential care home because they're a risk to the other clients in that home. You need a specialist placement for them, so there's a little bit of money gone into that as well. And then the last bit was, two other bits. So one is premium payments to care homes for rapid discharge. I mean, certainly, I know it's been a great sort of sense of frustration to the NHS that they can't always get people home on a Saturday and a Sunday at weekends and things like that. But care homes, the way they structure their rotas and things like that, the manager will often be having their downtime at a weekend. They won't be on site, and you're on a skeleton staff really to cover that weekend with a nurse and care staff, etc. If we want a flow of discharge out of the normal parameters of when the home works and has its staff in who would handle discharge, they'll need to increase staffing at that point. So we're looking at putting a bit of money aside as a premium to homes who are prepared to flex their rotas and things like that to get that in. And then the last one is just within our own council short-term support service. We're looking at an extension of that into overnight care for a few nights for people when they're first getting home from hospital to support them in that initial stage of recovery. Again, we won't recruit to that. We can't recruit in time for it, but we're offering overtime to staff within the council's own service to be able to do it. And that's the key cohort of what we're trying to achieve with that. So as I say, at this point, in terms of the report, we're looking for endorsement from the Health and Wellbeing Board, and I do apologise for that. It's not mine or Rachel's fault, it's the fault of the system. It would be far better if we were coming to you with a plan and we were talking through a plan about that, but the timescales don't allow it. But as I say, I'd welcome any comments on how we might want to handle that going forward, because as I say, I think it will be the same model for the next few years. Thank you, Chair.
Thank you very much. Thank you. Are there any comments? Yes, please. First one, and then
Just like
Derek.
to say I welcome the innovation. You've had to turn it around so quickly. There's some great things that you're obviously trying to accomplish in the next few months, so good luck with that one. I just wondered again, I'm a voluntary sector rep, is there any voluntary sector involved in the delivery of the home from hospital or hospital discharge schemes?
There is in reality on the ground, yes, and Northumberland Communities Together, which is our main interface with the voluntary sector now, are all over this with us in terms of alternate solutions, not just within the hospital discharge route, which they are used heavily for, but also in mainstream community provision as well. I mean, we still have a problem in the community, not just in hospital. At any point in time in Northumberland at the minute, we have around about 200 packages of care that we can't meet immediately. We're having to put alternative arrangements in place, and the voluntary sector is heavily involved in that. So absolutely, and we appreciate that help.
Absolutely, yeah, because just in another life, I ran a number of home from hospital schemes for the voluntary service management alongside the NHS. And we used a lot of what we call now community hubs to bring people into who were well enough, providing community transport, bringing people in, making sure they had a hot meal, checking they had shopping in, allocating transitional care. So it's good to know that you're looking at those alternatives within the sector, because we can provide a lot.
Derry, yeah, please.
Thank you. I think from the Health Watch perspective, I would say this is very welcome news. I think a lot of the things that you've set out in the plans and the use of both funds addresses some of the issues that people have come to us about. Certainly things around discharge and at weekends and that whole feeling of what's going on and not really feeling things are knitted together. So I think that's really important. I think some of the things that we're hearing at the moment around some of these issues around communication. So I would say that is a really big issue about how relatives and patients and service users are communicated with. They know what's going on and have confidence about where people are going and that it's actually going to work for them. So I think that's two very big issues. Just as I was listening to you, something else occurred to me as well. Is the thing that you spoke about last with the which sounds really innovative, actually, really interesting, around the cohorts and the flexibility, is that moving towards more of a model of like virtual wards and that type of thing, where you have much more built around the person type care in the community?
I mean, I'll let Rachel come in on the detail of virtual wards. I mean, ours, from the adult social care perspective, is focused on that maximising that care resource and getting the most out of that, but offering a solution that is more personalised to people. Because, as I say, we have been restricted with the traditional structure of, if we can only get you the care between 9 and 9:30, that's when you get the care. Whether or not you want it then, that's when the carer will turn up. I like the idea of this model. I think we need to test how efficient it is going forward, which we're getting a chance to do here.
Yeah, I mean, this is about hospital care, multidisciplinary working, which is out there, which is about supporting people in the community out of hospital. So yes, there is lots of work going on around virtual wards, and Alistair might want to come in on this as well, because we've been working with the Trust, and certain conditions like respiratory conditions, that's already in place, and that's been increased. Not necessarily totally linked to this, but it's kind of part of other funding streams. But it is about, nobody wants to be in hospital. It's about getting people safely out of hospital, and in their own environments, which is what we want to do. So yeah, there's lots more mileage to come, I think, from that.
Alistair.
I know the virtual ward, and then I'll ask you a question. So with regards to the virtual ward, I do think we need to think that virtual ward is a clinical environment. It's enhanced clinical care. It's not so much about the social care or the longer term need. So, for example, somebody whose current treatment is in hospital, who can have the enhanced clinical care in their own home, is where a virtual ward, or where they've got a need where they might have had a hospital bed. And so it's either step up or stop down, but it's very focused on clinical care as opposed to the wider determinants of social support and other bits, which are much more of a longer term trajectory in somebody's own life, which is entirely valid and really important. But I think we need to make sure that virtual ward is for a defined intervention, a defined period of time, and isn't part of an ongoing bit. But what we need to do is ensure that the virtual ward hands over seamlessly if somebody actually ultimately ends up with higher care needs as a consequence of what's happened to them. So I hope that kind of helps. But it is it's for the workers of the clinical environment that they're in.
The question.
I suppose the first thing is I would agree entirely with Neil that this is a really difficult area with regards to coming together with the plan, with the timescales, with the national changes and announcements of PCF and things like that. I suppose two comments. I suppose, and these are probably more around the discharge funds than the PCF. I think the first thing is it'd be really good to evaluate, does bringing forward people's wages, which is a significant amount of the sums involved, will that make any material difference to retention and recruitment? Because that may inform future years, and that's a significant chunk of the money. I'm all in favour of the real living wage, but whether or not that's going to make a material difference between now and April in terms of recruitment and retention in Northumberland, as opposed to training, support, all of the other bits that make a job really impactful. So there is a financial element to care home, but there's often some evidence that some of the ways in which their working environment is not necessarily optimal for retention. So I think it might be worth looking at that, given the fact that it's 1.5 million, just to see if that does create banquets for us going forward. I think looking forwards for next year, I think there's beds, I think certainly the Secretary of State is indicating that certainly nationally they think of that as a good thing. I know Neil's got reservations given our geography. I think we need to be able to work through this because I suspect there is probably greater mileage in the bulk purchase of care home beds. I agree that there's travel and patients' autonomy within this, but it's for a short period of time and often people are in a hospital bed, not necessarily on their doorstep, but given our geography. And I think we need to make sure that we get the flow out. So I'd be really keen that we could look at that together with a bit more purpose for next year, because I think there are further opportunities with the bulk purchase going forwards.
Okay, yes. I'll just come back on that. I mean, really helpful points, Alistair. Thank you. I mean, in terms of the wage increase, I agree. It's a very difficult one to actually understand whether we've had an impact or not. I mean, what we have done is we have consulted all of our regional colleagues on what they're doing as well, and I've got wider links into networks nationally. So I know I've got good links into London. I've got good links into the Northwest. Everybody has gone down this route, I think, in terms of the risk and the direction of travel with it. So we're not riding alone in Northumberland on that, and we will try and analyse it, but it is very difficult to say, would you have gone to work in the supermarket if we hadn't put the wages up? You know, it's a tricky one in terms of where we're at, but I get it. I mean, I have to say I'm going to be brave in this forum and say I don't agree with the Secretary of State around the bulk buying of beds at this point in time, certainly not in the context of social care beds. I think there is an argument around whether we bulk buy for intermediate care and a step through, but actually that threshold of moving into social care at the point that we start to talk about charging, which is a particularly emotive issue, that creates a real difficulty in a blocker when you're forcing people out. So I think the bigger discussion, and I mean, I haven't mentioned it briefly to Rachel, I had a conversation with Jim last week actually about it as well, is whether we get the ICB to think about regionally, have we got the intermediate care provision right, for the scale of what we're dealing with at this point in time and going forward, because I can't see this getting better in the short term. And I think there's a step change we might need in there. Buying up basic care home beds, I think, is extremely risky as a solution and outcome. And actually, if you look at Northumberland, there's very few homes sitting with full wings ready to convert into that at this point in time. So you're talking about small pockets of 3 or 4 beds at a time and mixing that in with residents. And I mean, many people, the key is in the title, they are care homes. They are people's own home. And we wouldn't necessarily, even in a crisis, I mean, some people might, I know, depending on your personality, throw your door open to let people in. And people are private paying for these beds as well. You know, they're paying up to £1,000 a week to be in a home for that service that you're then opening up almost. I realise we're in crisis, and I realise we need a way out of this crisis, and I realise parts of the country are in a lot worse situation than we are as well. So I get the level of reaction that's coming. But it's just, I mean, my job's to sense check that from a social care perspective. And that's what I'm doing with that. I think it is risky. But yeah, I think intermediate care is the key thing, though, and I think you're right in that sense, Alistair. Yeah, yeah.
I think that would be welcomed in terms of looking at how we maximise the use of the money. And I agree, it is that more intermediate care that I think we need to look at more producers.
Thank you. Wendy, you want to say something?
Thank you, Chair. Alistair, I do understand what you mean about the real living wage. I do understand that. However, I do think that we must value our care workers, because without them, we are snookered. And I do think that we do need to give them this real living wage.
Any other comments? No? Okay, so can we then confirm the endorsement of the main contents which Neil kindly presented, and also the contents of the additional plan as well? There are 2 sections to what Neil presented. Is that okay? We will confirm our endorsement. Yeah, the board confirms the endorsement. That completes the main items. Now we have to go to the forward plan. We do not have a meeting in February, but in March we will be looking at, where is it? Yes. I think Jill will give a public health annual report meeting. And also we will be working on thematic groups updates, because as you know, we are revising our health and well-being strategy. It's long due. So that would be updated as well. And some interesting items like living wage and 0 to 9 service updates. Okay, so but there is no meeting in February. Are there any comments? All right. Yes, Glenn, sure.
I don't have a microphone, so if I could just raise my voice slightly. I think we're in an incredibly difficult position currently with the situation around nurses, ambulances, and waiting times and discharges and adult social care and so on. Obviously, I work with the Vice Chairman, just asking to see if we could have more information on the true situation around getting appointments for GPs in Northumberland. There is a talk about the fact that people can't see their GP, therefore they're going to A&E, thus creating more of a problem than there already is with dealing with those people who need care. And it seems to me that there isn't any real data on that, and I'm just wondering if at the next meeting we might possibly ask that we do discuss this, because clearly if there isn't a problem with getting an appointment with GPs, we need to know that. If there is, then perhaps, so far as a Health and Wellbeing Board is concerned, perhaps we need to look at that a little more closely. So would I be able to request, please, that we do have a discussion about this with some information, ideally, so that we can look at what the hard facts show us in March?
I think
the simple answer is yes, if the Health and Wellbeing Board would like us to bring that, and we will speak to Pamela Phelps, who's the Senior Commissioner at this ICB for Northumberland, who would probably be very happy to come and talk to us.
Thank you.
Yeah. Okay, so there's some item for March. We will take that out as well. We'll take that in as well. Thank you, Glenn. Yeah, I think you mentioned this earlier on as well, but thank you for coming back on that one. So now we are fixing it. As far as I know, there are no other urgent business. So next meeting, as I said, it'll be 9th of March, Thursday, usual day, and 10 a.m., usual time. Thank you very much. The meeting is concluded. Thank you for coming here once again.